depression screening or themselves did not complete the depression screening. We're not asking the practice to focus on the acute visits. We're asking the practice to focus on the annual preventive visits where that depression screening happens. So this is where the opportunity lies, so we can meet our benchmark, if you want, is to increase screening rates by 15% per year. And to do that, we want to try to maximize the number of screens that occur during the annual preventive visits. With that one pager also, we're reminding you of the depression screening toolkit and the link to that. We're reminding you that our team is available on a weekly basis every week through this behavioral health team consultation time that we set up on Tuesdays. We are also reminding you of the email that you can use, and we encourage you to use for anything from consultation to any questions you may have related to behavioral health concerns that you have with your patient or practice. And obviously at the end, again, our email, and then the optimization team, Willie's email here is listed in case you have any technical questions. That's what I wanted to share with you and maybe answer some questions that you may have. Elizabeth, did you want to add anything to what I'm saying?
I think you covered it very well. The only thing I'll note is that, as George mentioned, with some of the practices data not looking correct, to be honest, some practices have already been engaging with Willie, as George mentioned, which is great. Some practices, we think that the data is flowing through correctly already, but for those where we really already see an issue, we're going to be putting a note in the email as well to let them know. So if they're able or willing to engage, we can work with them to make sure we're.
You're gone, Elizabeth.
Good. Any other questions?
My colleagues at AHP can tell you I have had more headset issues this pandemic than I ever imagined possible. I don't know where I lost you, but just we're going to be adding in an additional note for practices where we think the data looks a little bit off, just to note. We don't want to alarm anyone when we send this out. So we want to make sure
we have a 2-minute limit on your microphone, and then we mute you.
Fair enough. Thanks.
Thank you, everyone.
Thank you, Dr. Nasser. Thank you, Elizabeth. Okay, we're moving on to the Honorable Dr. Teeters and Kim Povic for the 2021 incentive program.
Perfect. Thank you very much. So we are going to Renee, do you have our slides? Yes, you do, of course. So as we have talked about before, and we have presented previously at PCP Advisory, one of the things that has become clear is that we need to continue to advance how we engage with all of you, how we provide actionable information, and ultimately how we continue to improve our performance. We, really you, have done exceptionally well when it comes to quality metrics, but as we'll talk about in a minute, that is only half of our contract. We also have to find ways to bend the cost curve. As we have developed these IPCs and other initiatives, we've begun to work towards that, but it became very clear as we talked about this internally that we did not have an incentive reward plan that reflected the need to move both towards superior quality performance, but also lower cost performance. So what we're going to present tonight is what we are proposing as an iteration of our incentive reward plan. I can honestly say for most of the people on this call, this will be an enhancement, or would be anticipated to be an enhancement to how you are getting rewarded today through gain sharing and incentive payments. But for members of the network who may be less engaged or lower performing, there is a potential that there could be lower reimbursement in those cases. So if we can go ahead and go to the next slide, Renee. So this is not to be overly dull, but this is essentially how things get paid out today. So we have a contract with our payers where we are given a per member per month rate. and we pay the lion's share of that out to you all based on attribution. So this means the number of patients that are covered under our value-based contract. And as you can see here, there's a quarterly payment of $1 per member per month that is paid out just for having those members be part of our contracts. You're bringing those members to us, and that gives us some earnings just for clinical integration dollars that the payers pay to us. Obviously, we also use those clinical integration dollars for support of our care management team, operational costs of the network, but that is direct payment to all of you, regardless of how we perform in gain share. We also have a quality incentive that has historically been paid in March. That is another 40 cents per member per month, so $1.40 total, that is paid out based on your quality performance from the preceding year. So this is your quality metric performance. And now for the last couple of years, it has been paid in 3 tiers, this bronze, silver, and gold. Bronze is if you earned 65% of the possible points for the metrics that are applicable to you. So if you're an internal medicine practice, obviously you cannot perform to PEDS metrics. So we would not include them in your metric calculation. If you earn 66 to 89% of points possible, then you fall into the silver tier. And in the last year or so, we've added the gold tier because we've had so many practices that have been truly exceptional performers that are performing at or above 90% of points achieved. And that was really to reward those who have gone above and beyond to be high performers in the metrics across the board. There is then the gain share payment. Obviously, there is the potential in any given year where there is no gain share to be paid. And in that case, that gain share payment would be 0. Because of AHP Insurance Company, there would never be a time that we would anticipate having to come back and collect money from the network because the insurance company protects us and we can pay any losses that we experience out of that. But if a gain share is earned due to excellent financial contract performance, we generally pay it out on 3 tiers. There's a base amount, which I've now been referring to as the participation trophy. Everybody gets the same base amount, regardless of your performance. There is the quality incentive that is paid exactly like the quality incentive from March. So back on that bronze, silver, gold pattern. And then there's also a smaller attribution component that basically is the way that we move all the money that we have earned in that calendar year out to you all as gain share payments. If you go to the next slide, Renee. As I had alluded to, so the clinical integration payments, these are dollars that the insurance companies are paying to us to manage a population. That is how your attribution payment is going out. And that 40 cents from that pool is what guarantees us a quality metric distribution that goes out in March. But what you will notice is there is also the requirement that we have to perform to a budget. So based on the cost of managing our population, the total cost of their care for the preceding year, we have to perform to a budget target in order to earn any shared savings. If we do exceptionally well in quality metrics, but we lose money year over year, there will be no shared savings in the bank. And so there would be no gain share to distribute, which means that right now, because our distribution of finance is based only on attribution and quality metrics, we are not currently pushing the network to perform to that cost factor. And so that has been a weakness because ultimately that's what we want to do to move our overall performance and revenue in the positive direction to enhance everybody's earnings as part of value-based care. Next slide. So this is our proposal to change that. So we're going to still pay attribution as we historically have, that will not change. But rather than everything else revolving around quality metrics only, we are going to now break it up to where 60% of the disbursement will be paid on quality metrics. 30% will be based on performance to these IPCs and pharmacy. We're going to talk about that more in a second. These are initiatives that are meant to bend the cost curve and enhance care of our patients. So this is how we are going to achieve the cost savings in our population. Quality metrics may allow us to achieve savings, but sometimes that savings may not be rendered within the terms of the contract. So the only way we're going to perform to that budgetary consideration is to decrease our total cost of care or variation in care. And that's how those IPCs and pharmacy initiatives are structured. Currently, we have different practices who are willing to engage, who are not necessarily as eager to engage. And there is no reward for those practices who are engaging in these efforts. So we felt like it was important to move our overall performance to highlight that as part of the reward incentive. The final piece is citizenship. None of this happens if there's not active engagement between you and your practices and the AHP team. Whether this is attending meetings, whether this is interacting with our pharmacy team or our care management colleagues, we will set out kind of what we think a fair list of engagement strategies will be. But certainly, we want to reward those who are active participants who are helping to move the work forward. And so we felt like the citizenship classification would be a good category to add to foster that engagement. Next slide. So now what the new story would look like is that we will be paying the attribution, which basically means you have your patients, the size of your practice basically determines what that payment looks like, and it's based equalitarian based upon the number of patients and the money that's coming in, and you will continue to receive that $1 PMPM on a quarterly basis as you always have. The value incentive will retain that 40 cents that was paid out in March previously, but we will now add to it any gain share dollars to create this reward bucket from which we will pay 60, 30, 10% on quality measures, IPC pharmacy performance, and citizenship. I want to highlight the flat rate for IPC pharmacy and citizenship. So one of our goals, if you guys harken back to that cost quality grid I showed a couple of months ago, where percent of quality metric points earned was on the x-axis and cost per patient, average cost per patient was on the y-axis. And we saw how everybody's dot kind of splayed out on the graph, and everybody immediately became interested. Were they the good practice or the bad practice? The goal is to move to higher quality, lower cost. We realize that there is no one practice that can fully move us in the direction of value-based savings. So the goal is not that you will necessarily have to achieve a set reduction, but rather that you are engaging around these IPC pharmacy initiatives, whether that's achieving a certain percentage of patients who are, qualify for switches, or that we at least have a discussion with the pharmacy team as to why those patients should not be switched. If it's readmissions that, your office is engaging in the 5 contacts and doing the 3, 4, and 5 contact at some percentage of the time, just so that we have engagement across the network, which ultimately should yield significant savings and further funnel into this gain share pool. Likewise, the citizenship is a flat rate. Either you're participating or not. There's not going to be a you participated better than somebody else. It's not graded on a curve. It's a yes or no kind of dichotomous variable. I think that's all. Can you go to the next slide, Renee? Can you go to the next slide? Thank you. So that's all I have for the incentive plan. The way we will further address that is we are developing what is a new version of the Triple Aim report. That Triple Aim report is we're calling the Provider Engagement Report. We anticipate that will be delivered quarterly. We are also going to start planning a series of Zoom meetings for practice visits. Some can be live, some can be Zoom, but where we will intend to review that Provider Engagement Report. It will highlight your current metric performance and your trailing year performance, so you can see where your trajectory is heading. For the IPCs and pharmacy initiatives, it will both say where you are today as far as your practice level performance, and it will give you actionable patient lists to say, here are the patients you're going to see in the next 90 days who are applicable to this initiative, who you can move the needle by doing some enhanced care delivery. And then the citizenship will just be a check mark, yes, no, you've met one or more of these criteria to earn that bonus. So we will be continually working with you in your practice to update you on your progress, and hopefully seeing further progress for the entire network to ultimately meeting these goals. I know that's a lot to cover in a very brief period of time. Any questions about that piece? And I'm not expecting everybody to be Wall Street ready and understand every detail of this. I'm happy to share it with you. But we wanted to at least put out there where we're thinking. And obviously we'll be meeting with you and your practices to discuss more and give you more actionable data of how it applies to you.
Chad, what performance year is this going to apply to?
So we're going to start applying this in 2021. So it'll be obviously based on your metric performance that we'll be reporting to you on next year. But then the IPCs will be working with you as we roll those out over the course starting in 2021. All right. No further ado. We can move on to post-acute care, and I will hand the mic to Kim.
Great. Thank you, Chad. My name is Kim Povik. I don't know all of you on the call today, so it's nice to meet you. Several of you I've met before. I work closely with Chad on our large clinical initiatives, our integrated practice committees, our IPCs. And today we are going to dive into post-acute care. And Chad, please chime in as we go along here. So last year, as we were looking through some of our data, some of what surprised us was the increase in the number of patients who were utilizing post-acute care, but what was more startling to us was the increase in costs. So as you can see from this chart, from 2018 to 2019, the number of patients utilizing post-acute care increased by 62%, and the cost increased 73%. Initially, Chad and I had thought it was just ED utilization and readmissions, but as we looked at the data, both of those actually trended down from 18 to 19. And as we dug into the data further, it was actually length of stay that was driving that 73% increase in costs. This is all AHP Excellus data. We had some conversations with Excellus about this as well, and they also saw similar increases in their population, not only within our AQUA, but within all of their patients across their coverage area. So after looking at this, we said, gee, there's some challenges here. What can we do about it? And so that really led us in, and really Chad, I want to give credit to where credit's due here. That really led Chad to start conversations with some of our post-acute care facilities locally, and also working with our directors of social work at Strong and Highland to really understand from their perspective what may be contributing to this. Next slide. So what that led to was the creation of what Chad has termed a high performance network. And the goal of this high performance network overall is to encourage patients to go to what we're terming high value facilities. A high value facility is a facility with a lower length of stay, with lower ED utilization, with lower readmissions, rather than a high utilization facility. We looked at probably 44 different facilities that we discharge AHP patients to, and the range of ED utilization was from 7.5% all the way up to 42%. So these facilities range in their quality pretty significantly. And so what's at the core of this initiative is moving AHP patients from high utilization based facilities to high value facilities. And these patients have the same risk score. So I'm now going to orient you to this diagram that you're looking at. So as you know, this all starts with discharge from the hospital. We've broken out this initiative into two phases. Phase 1 is represented in the navy blue box on the top of your screen, and phase 2 is represented by the goldenrod rectangle on the bottom of your screen. This demonstrates how patients and dollars will flow through this initiative. The goal of phase 1 is to test the mechanics. So can we successfully encourage patients to choose these high value facilities? And can we simultaneously encourage these high value facilities to choose AHP patients? As we've looked at some data from the inpatient side, what we've seen is that the majority of AHP patients choose the facilities that are going to be in our pilot, but the facilities aren't choosing these patients. So this all starts at hospital discharge. We've partnered with both hospitals, Highland and Strong, and for them, it's a win. It's a win if they can have guaranteed bed placement, and it lowers their length of stay on the inpatient side. From the facility side, it's a win as it increases their fee-for-service revenue. And from AHP, it's also a win because patients will now have a lower total cost of care. Earlier, Chad was talking about how we're on the hook for bending the cost curve. So when we talk about that total cost of care, we're talking about the same thing. And this is one initiative to help us accomplish that. In phase 2, we would layer in quality and utilization-based metrics. We would collaborate with the payers and with the facilities to choose what these metrics look like, recognizing they're accountable for other metrics elsewhere. Again, lowering ED utilization rate, readmissions rate, length of stay would all be quality and utilization metrics we'd add in, and that will therefore lower that total cost of care as well. All of those dollars saved would go into a gain sharing bucket that we would then gain share the facilities involved in the pilot. The pilot sites we're looking at thus far are the 5 Shagra homes. So the Jewish home, St. Anne's, St. John's, Episcopal, and the Friendly home. We've also included the 2 U of R facilities in this pilot as well. Chad, anything else you want to add in here before I move on?
No, I think you covered it pretty well.
Okay, wonderful. Next slide, Renee. So the workflows. So what is this actually going to look like? How is this going to come to life? So this slide, we're not going to go into every single detail on this slide, but I think it's important to call out the 3 types of patients that will be included in this pilot, and also talk about how the workflows will be a bit different depending on the patient type. So we've coined the, I should say we're calling the 7 pilot facilities the Big 7. So the first type of patient that would be included in this initiative is a Big 7 patient. So these are patients who would typically and historically go to a Big 7 facility. And these patients are still going to go to the Big 7 facility. They're still going to choose those facilities, and that facility, the Big 7, are still going to choose those patients. The workflows for them will not change. The second type of patient that will be in this initiative is the prior low value facility. So these are patients with the same level of risk as a Big 7 patient, only they've historically been going to high utilization based facilities. So in this scenario, the intervention here is going to be around choicing, and our inpatient discharge coordinators working with these patients and families on choosing the Big 7 facilities, and simultaneously us working with the Big 7 facilities for them to choose these patients. The third type of patient that will be in this initiative is the difficult to place patient. And so these are patients who might need a one-on-one, who have expensive medications, who may need transportation back and forth to dialysis. These patients are not accepted by Big 7 facilities. So the net new item we are adding to this initiative is something called a community pool, and that's highlighted in green here. I'm going to dive into the community pool in 1 second, but before we move on to talk about the community pool, I think it's important to highlight here the red text that you see is really the net new addition of adding outpatient care management into discharge discussions, and into discharge discussions when the patient leaves the hospital to the nursing home, and also when the patient is about to leave the nursing home and getting handed back off to all of you in primary care. And so we've been working with Daryl, we've been working with Elisa and several other of our care management leaders on what that collaboration is going to look like. And they've been wonderful conversations with the discharge coordinators at the nursing homes and at the hospitals. So they've been very encouraging. As Daryl always reminds us, certainly far more work than we ever imagined these conversations would be, but they've been incredibly fruitful and we're really excited about them. So now the community pool. Chad and I oftentimes think about the community pool as a grant or a scholarship program that would incentivize the Big 7 facilities to take patients they would have never taken before. Again, we need this incentive to encourage these patients smoothly transitioning out of the hospital, opening up more bed days for other patients on the inpatient side. There's a group in Syracuse who has successfully stood up a community pool, and it involves the 3 large hospitals, Crouse, St. Joe's, and Upstate. And the model that they're currently using out there is the hospitals each pay into the community pool. But because the hospitals pay into this community pool, it's the expectation that the nursing homes in this community pool are going to not only accept these difficult to place patients, but they're going to get a higher volume of their bread and butter patients that they want to take day in and day out. So there's incentives for both. We're just embarking on the pilot. So we by no means feel like we're going to have a fully up and running community pool in 2 months, but we're certainly going to get a model of the community pool stood up so that we can start to figure out out the mechanics now and into the future. Chad, other things you'd say about the community pool?
No, I think, the nice thing is all these things are kind of the necessary enticements to get the play for the nursing home facilities to partner in this, because ultimately there would just be a loss of revenue for the nursing homes. The hospitals are playing, so everybody gets to win in this. And ultimately, we're looking at a $4 to $5 million anticipated savings for AHP if everything delivers as expected. So it's kind of a win-win all around.
What questions do you all have? Okay.
Silence.
I think we can, I think osteoarthritis is last.
Yep.
I think we can go to the next slide, and Chad, I'll turn it over to you.
Finish on osteoarthritis. So we had discussed this, I think, in several different venues. But one thing that we had seen as we looked across our data is when we looked at our AHP patients, one of the places where we see that there is a large amount of value-based loss is for our patients who need large joints, so hip or knee, joint replacement. When they go out of network, it generally costs about $4,000 more per joint replacement than if that joint replacement is done in network. Now, certainly to the hospitals that are part of AHP, that's also a loss of revenue of about $20,000 direct fee for service per case. So again, this is a place where kind of what I call the unicorn initiative, where we can enhance fee for service revenue for the hospitals. We can generate value-based revenue for our network. And to go a step further for patients, when joint replacements are done out of network, they're more likely to need post-operative rehab. They are more likely to be readmitted, and they have a higher reoperation rate over the next 5 years. So not only is it better financial outcomes, but it's better quality if we can keep these joint replacements in network. When we started talking about this, what we heard loud and clear from many of you was that access is not always great. When patients have exhausted their conservative management resources and get referred to orthopedics, predominantly through the U of R, sometimes getting them in to see one of the UR orthopedic surgeons can come with a delay of 3 to 6 months, whereas other local orthopedics can get them in much faster, and hence the leakage. So as we started to consider this, the idea was, could we get patients intertwined into the orthopedic management pathway sooner, perhaps enhance the conservative management to even avoid need for joint replacement, but ultimately by getting them into the system, streamline and retain them so we decrease that out-of-network leakage. So as we started to conceive of how to do this, this was also one of our first real successful engagement strategies with our subspecialists. So working with Paul Rubery from orthopedics, we discussed the potential of creating a non-operative ortho service where we could get patients into such a pathway, provide enhanced non-operative management, and hopefully avoid joint replacement, but if not, to at least keep those patients in the system. So on a whim, we defined a group that we thought would be a reasonable amount of arthritis problem as anyone who had had 3 or more visits in the preceding 12 months with the primary diagnosis of osteoarthritis. So that we considered to be a significant impediment in that person's life. We went further to say we also wanted to look at folks who had 3 or more visits for primary diagnosis of large joint osteoarthritis, who had also not seen an orthopedic surgeon in the prior year. And what you can see is the group that had large joint osteoarthritis, 3 visits for osteoarthritis, and had seen an orthopedic surgeon was just over 8,300 people in this chart, group A. And the people who had 3 or more visits who had not seen an orthopedic surgeon was just over 2,700 people, and that was group B. If you follow those patients out and look at their cost of care, obviously the operative intervention weighs in because you have to see an orthopedic surgeon to get a surgery. So that group A group has a spend of about $22 million plus per year. The non-operative group, the group who did not see an orthopedic surgeon, had a spend of about $150,000 per year. But the per capita spend is just about $12,000 in the group that sees an orthopedic surgeon, obviously heavily weighted by those who get surgery. And the per capita spend in the non-operative pathway was $270 per year. So what we constructed after reviewing this with Paul Rubery was, could we conceive of this non-operative pathway, and could we come up with a multidisciplinary management approach where we could consult on these patients, make recommendations either for physical therapy, enhanced medical management, or even things like visco supplementation, joint injections, the like. So working with him, orthopedics does have a fledgling non-operative ortho team. Largely are sports medicine trained physicians, but some of them are some of the orthopedic surgeons. And basically they're involved in this conservative management pathway. So as we devise this out further, if you go to the next slide, Renee, what we kind of conceptually came up with was this. So we immediately excluded small joint osteoarthritis. There's just not a lot of variation in management nor revenue to be gained. But obviously the non-operative care that you guys deliver is excellent and all is well. But if the patient is starting to have more and more visits either to primary care, to urgent care, or ED with osteoarthritis, then they're not being managed successfully with primary care alone. So what we had conceptually come up with was this referral of at least half of this population, half of that 2,700 patients, into this non-operative orthopedic care. The cost of that is fairly minimal, but the hope would be that this would better deliver conservative management to the patient and give a care plan. It also could help identify what would be the barriers to that patient if and when they may need surgery. So if a patient has a BMI of 43 and they have an A1C of 9.2, it is much easier to hear, look, you're likely to need a joint replacement in the next year, but you're going to have to get your BMI under X and you're going to have to get your A1C under Y before you'll be an operative candidate, than it is to hear you've exhausted all your options, you need joint replacement, but I won't operate on you until you do these other things. The hope then is for those who get the non-operative care that we can reduce progression to total joint replacement by 20%. And Dr. Rubery feels that both of these numbers are very realistic. And if we were to do so, you're looking at about a net savings of somewhere north of $7 million per year in the first year if we were able to achieve those targets. The interesting thing is this data is based on Excellus patients only. And that's only because the easiest group to get the data. We have contracts with our MVP population as well. So this is one where we could affect this both in Excellus and MVP contracted patients and escalate that savings even more. The non-operative team has the capacity to handle this volume of patients, and they are willing to hire staff to guarantee one call access. So that if your team makes the referral, you would have one phone number to call and they would get them in with the next available. And then that team could help funnel them to a surgeon if and when the time arises. The ask for you all is obviously you would have the option of referring to this team at any time, but we would continue to run this list of patients who have met that 3 or more visits criteria within the last year, who are not tied into one of these pathways, and send that to you and or your care manager for review. And the ask would be, consider whether or not you think that patient would be a reasonable candidate to be referred into this pathway. Obviously, it's only successful if we can get the volume of patients going into this management strategy. The hope would be that it would decrease the burden on you guys of seeing these patients who really are exhausting their outpatient management options, and possibly provide some of these other relatively low cost options that may enhance their management and decrease their outcome or decrease their operative risk outcome. So that's really the discussion here. So all told, our goal for this year with these IPCs was to get somewhere north of $10+ million of anticipated savings. If we're able to deliver on this book of business, we should be able to achieve well north of that.
Just a quick question. Part of Chad and I's curiosity, and we have some ideas, but we'd like to to get your thoughts. What are the reasons that you hear from patients that they go out of network?
This is Val Newman here. I'll say that one of the biggest reasons is the question of whether they feel they have someone who's really listening to them and addressing their needs. So a lot of times they'll have a first consult, they feel they were blown off or not addressed in the way that they wanted, and then they pick somebody else to kind of start over with. So it's really how engaged and how responsive the providers and access in case if they do need a procedure or are contemplating joint replacement, the timing. So that those have been the major factors.
And then family or friends, I would say, is another one where they've heard a name and they want to go to that particular name that someone's given them.
Yeah, I think in the southern tier, I really don't know who's in network and who's not. So just education of the primary care would help.
Sure.
Chad, a question I have for you, this non-operative orthopedic care, does this include PMR? Because PMR has expanded significantly their non-op service. And there's these young guys who are whizzes with ultrasound and who can do injections and who seem to be very available. They're highly capable people.
Yeah, so, Ravi Patel was a member of orthopedics and is now kind of split off to run PM&R. But still is very much in collaboration with them. And so some of this non-operative conservative management does involve these procedures like Cooley for geniculate nerve ablations, the visco supplementation injections and the like, which can be done by either of those services. And they do share that process back and forth. So absolutely, that would be part of the management strategy.
Because I'd like to highlight that they are very available and they see patients literally within a week or 10 days.
Yep.
And being young, they're definitely on email, they're on text, so you even get directly with the actual physician and they're very willing to, kind of be responsive and engage with you.
And I mean, obviously we all have our kind of residency fueled anecdotes of relationships with surgery, but I will say, this non-operative team is actually very engaged in this idea and very interested and willing to make sure that this is a positive experience, both for the patient, but for you guys as well. So I do think there would be a good response. I hope. If not, obviously, then that is something we have to address as well.
So building on something Dr. O'Connor said is, I think a very clear laminated sheet of providers and which pathway they're in, and maybe what joint they're interested in, whether it's knee or hip, right, or shoulder, I think is going to be crucial here. So I think it's going to be, very good communication, and maybe putting both orthopedic, non-op, as well as PMR on this grid would be helpful.
Absolutely. Yeah, that shouldn't be hard at all.
One other comment I would just make is that for a lot of patients, they go once, they're seen, and then they kind of are bounced back and they don't want to kind of go back because they didn't feel much have been done. So I think the idea of sort of holding on to these people and continuing to offer additional modalities, I do think that the PM&R team is terrific, because I think that then they're offering much, much more to these folks. But the key is sort of how do we create this continuity of tracking so they don't kind of leave the system and then not re-enter it at a later point.
Totally agree.
And I think Russ Maggio in the chat brings up a great point, which is, that offsite schedule, central line, not really being able to direct to a particular person or to direct to a particular group makes it very difficult at times. So
the other thing I wanted to say, Diego, is that post-op pain management has been really challenging, particularly with URMC providers. We have multiple cases where patients are told they're given 7 days of narcotic, and then you talk to your PCP for any additional pain management. And it's been very frustrating to deal with the offices. Many times you do not speak with the physician. You'll speak only with the nurse practitioner. As a physician to physician, you'll get a nurse practitioner or PA. Not that that matters, but when you have a challenging patient who's very upset about their post-operative care, It's been extremely difficult to deal with many of the subspecialties, not just orthopedics, but, we've most recently had several situations where orthopedics has sort of just dropped the ball.
And I will say, so both Paul and the non-operative team were interested in coming to kind of be involved in some of this bi-directional feedback. But we intentionally kind of wanted to introduce this first to start the process and have some of this discussion. We can certainly bring them back to have some of these conversations in further detail going forward, but we'll definitely relay that information also. And as I said, we did highlight the access issue. And so that was one of the reasons that they have offered the ability to have that one site. And obviously they're going to be moving to their own central orthopedic site over in the Market View Mall space. So they're trying to improve some of this access issue that they've heard loud and clear.
Yeah, as Diego, as you pointed out, what I've had to do with a lot of providers that I referred to, subspecialty providers, is we just text amongst ourselves because it's so challenging to utilize the U of R's system to get in touch with a provider. And, most of the offices are not willing to share back office numbers. They're not willing to share, a sort of another venue to access a provider specifically. So, and the providers themselves, the docs themselves are very frustrated by that too, across the subspecialties. One example I just had with urology, and the urologist said, Russ, just text me directly. Here's my cell phone, because this is so frustrating for us. They've taken away our secretaries. We have to call over to Elm Grove Road to get an appointment. These people barely know who the docs are. And they just see, this is Dr. Gentile. Oh, he is a urologist. Okay, we can get you an appointment in March of 2021. That's just like, it's very challenging.
Yeah, I've definitely heard that as well.
And something else I want to highlight that you said, Russ, which is very important. They can't say, just call your PCP for the next step, right? So if that has to happen, I think, just as Russ said, it has to be communication, right? So if they really feel like they are not the next step, then call us. Then call us and say, listen, I did this knee surgery. I gave them meds. What's the next step? Should they see you? Should I do something else, right? But not just have that, call your PCP, and hopefully it all works out.
Right.
Yeah.
All right, this is great. We will definitely take that back, and they are eager to hear. So this will give us a running start. So I appreciate it. And I think that's all we have for you tonight.
Anybody who didn't put their name in the chat for attendance, please put it in before you log off. I would appreciate that. Great.
Anything else for the good of the order? Otherwise, I will recommend that we convene for the night.
Good night, everyone.
Thank you very much, everyone.
Thanks, guys. Have a great one.
Good night.
Bye. Bye.
Bye, everyone.
Bye, Manny.
Hi, Diego.
Bye, Emmanuel. Thank you very much. I wish you the best.
Thank you so much.
Yeah,
Good knowing you.
You're a great professor. You got to keep teaching me, even if you're in DC.
Take care, everybody.
Hi, Diego.
Bye-bye.
Bye-bye.
Bye-bye.